Hi, Emily. Thank you for joining us on MD Newsline. Can you please introduce yourself for our audience?
Absolutely. Thank you so much for the opportunity to be here. My name is Emily Zboril. I am a fifth-year PhD student at Virginia Commonwealth University, so I'm in the last year of my doctoral training.
Yeah, and you had a really interesting poster here at the Endocrine Society 2025 annual meeting. Can you please tell us a little bit about your work and your research?
Absolutely, I would love to. So I study bone metastasis of ER-positive breast cancer and the clinical challenge in treating patients with this type of metastasis. So ER-positive breast cancer, the ER stands for estrogen receptor positive breast cancer. These cells are driven by estrogen signaling to grow and proliferate. And what's really interesting about bone metastasis of this type of cancer is that cells in the bone microenvironment are really tightly regulated by sex hormones like estrogen. And the drugs we treat patients with in the advanced and metastatic setting usually downregulate or degrade the estrogen receptor in a universal way. So fulvestrant, elacestrant is a new compound that's been approved for a couple of years. What these drugs do is they just kind of ablate estrogen receptor signaling in both the cancer cells and the bone microenvironment. And this can lead to symptoms like bone pain, osteoporosis, increased risk of fracture. But there's some evidence to suggest that this osteoporosis can sort of exacerbate or accelerate metastatic outgrowth in the microenvironment. Because if you can imagine, bone tissue is a hard space. And so when the metastatic cells come in, part of their activity is to resorb bone and cause osteoclast bone resorption to sort of carve out a niche within the bone tissue. And so we think that by finding new treatments that will be bone protective while still downregulating estrogen signaling in the cancer cells, we can provide patients with not only better treatments, but treatments with less side effects. And so my poster and my talk was all about lazofloxifene, which is a new compound. It's in a phase 3 clinical trial with abemaciclib versus fulvestrant and abemaciclib for patients with advanced metastatic ER-positive, ER-mutant disease. And so what I'm really focused on is lazofloxifene as a monoagent in the bone metastatic setting. This drug is approved in some countries for osteoporosis treatment, so it's known to be bone protective, which is an important part of interrupting this crosstalk between the metastatic cells and the bone cells. And we've also shown that it's very effective in preclinical models at reducing overall metastasis as well as bone-only metastasis, which is really exciting for us. And we think that that has something to do with this partial agonist activity. And when I say agonist activity, essentially what I mean is that the same compound can stimulate the estrogen receptor to transcribe genes in the bone cells, similar to estrogen, but can downregulate or antagonize ER in the metastatic cells in the bone microenvironment. And we think that this is due to recruitment of transcription factors that are different in the two different cell types. So particularly, we're interested in osteoblasts in the bone. So these are the cells that make bone matrix and calcify it. They're the bone-producing cells. And we think that lazofloxifene enters these cells and binds the estrogen receptor, and it goes to the DNA and recruits proteins to turn on genes to make more osteoblasts or stimulate osteoblasts to make bone. And that these proteins are different between the osteoblasts and the cancer cells in the bone microenvironment. And so that's sort of the next step of our work, is to prove that mechanism, to see what the proteins are that are changing the transcriptional capacity of ER under lazofloxifene stimulated conditions. And additionally, to find novel combinations. So we're really interested in endocrine therapies with other inhibitors. So we are looking at different cell cycle inhibitors that can preserve the viability of osteoblasts or other cells within the bone that are important for homeostasis while still decreasing metastatic burden, with the hope of finding something to enhance this mechanism so that patients can have better outcomes, longer survival, because right now bone metastasis is not a curable condition. So patients who receive this diagnosis will die with it. And so it's really critical that we find new treatments, combination treatments, to provide a better standard of care for patients with bone metastasis of ER-positive breast cancer.
Interesting. So talk to me a little bit about how far away we are maybe from getting to maybe clinical trials. What work is there left to do in this?
Absolutely, that's an excellent question. So right now, the Elaine 3 clinical trial is, I think, finished recruiting and hopefully soon starting to treat patients. And that will be testing lazofloxifene and abemaciclib versus fulvestrant and abemaciclib, which is already an approved combination. So we'll see what those results look like. Those patients will likely have bone metastasis and other visceral organ metastases, or advanced recurrence. So hopefully with the data that's collected from that trial, we can start to stratify patients based on metastatic sites, and see if there is a true benefit for lazofloxifene in the bone microenvironment. And after that, I think that there will be many more clinical trials with lazofloxifene. I'm really interested in how it behaves in the bone microenvironment, but I think that there's a lot of clinical potential for this compound to possibly replace tamoxifen as an adjuvant therapy, because it has a lower side effect profile. It's bone protective. It also doesn't increase uterine hyperplasia, which we see a lot in the clinic, patients treated with tamoxifen.
So when we talk about breast cancer, a conversation that we often have is about epigenetics and how different people respond differently to different treatments. And
Absolutely.
has there been any conversation when it comes to bone metastasis of how outcomes might differ among people with maybe different gene factors, or are there demographic factors or other things that kind of impact patient outcomes or even response to
Absolutely.
treatment?
That's an excellent question. In the metastatic setting, unfortunately, we know so little. Bone metastasis is a very difficult field to study, so there's not a whole lot of stratification in the metastatic setting. But in the primary tumor setting, we know that there are different subtypes of breast cancer that are ER positives. There's luminal A and luminal B, lobular breast cancer. And we really don't know very much about lazofloxifene. We're still learning a lot about it, but it's an important question to ask. And I think that as we progress through clinical trials and have more research done in the preclinical setting as well, that will hopefully identify some markers or some way to see which patients will benefit clinically from different treatments like lazofloxifene. But in general, estrogen receptor modulators are very effective at downregulating estrogen signaling in the cancer cells. So hopefully we'll be able to expand the patient population that is receiving treatments like this.
So what led you to focus on lazofloxifene specifically?
Absolutely. So lazofloxifene is a new generation estrogen receptor modulator, or SERM. Tamoxifen is a SERM that has been prescribed since the 70s and 80s. It has been kind of a standard of care adjuvant therapy for many, many years. And so we were really excited about an estrogen receptor modulator that might improve upon the pharmacology of older generation compounds. And specifically lazofloxifene, because we knew that it was bone protective. Like I said, it's approved for osteoporosis treatment in some countries, and has shown clinical efficacy in phase 2 trials with the FDA at decreasing ER-positive breast cancer burden.
Interesting. One of the things I find fascinating is when we talk about even preclinical research is how technology is coming into play. Right now I'm thinking about machine learning models being used to analyze past clinical trials. I know we're preclinical right now, but how does technology play a role in your work?
Oh, technology is everything in our work. I know you were asked a question about biomarkers earlier. So right now we are trying to evaluate and sort of deduce what the mechanism is that lazofloxifene is able to act as a partial agonist in the bone microenvironment. So sort of the new technologies that we are utilizing are spatial transcriptomics. So sort of the future directions of our projects is to be able to spatially evaluate metastatic cells in the microenvironment, as well as bone cells, proximally and distally to metastasis, to see how maybe, being nearer to the metastasis can change how bone cells behave. And then we can look at, under normal conditions and treatment conditions, does that change to be more favorable for patient outcomes? So that's one new technology that we're really excited about. And another is proteomics. So proteomics is kind of a newer hot topic. A lot of people have studied RNA for many, many years, but now we're able to look at globally what's happening to the proteome and the phosphoproteome. So functionally, what are these proteins doing? So one of our future directions for this project is to collect cells that have been treated with lazofloxifene and look at, what is ER really interacting with? What is the mechanism this is, how this is happening? Are there biomarkers that we can identify that will tell us which patients will respond best to lazofloxifene? So yes, proteomics is a very exciting new field for us as well.
So how does lazofloxifene compare to other SERMs like raloxifene and tamoxifen in terms of bone-specific outcomes and side effect profiles?
Yes, so raloxifene and tamoxifen have bone protective qualities as well. I think that lazofloxifene is a more effective drug when it comes to the bone microenvironment at protecting the homeostasis of that organ. But I think the real advantage to lazofloxifene is that it is really able to downregulate estrogen signaling in breast cancer cells extremely well and reduce their viability in the preclinical setting better than tamoxifen. So that's something we're super excited about.
What are some of the common adverse effects observed by lazofloxifene regarding bone and maybe non-bone tissue?
Yeah, that's an excellent question because so many organs in the body are regulated by estrogen. So lazofloxifene is bound to have organ differential effects. Tamoxifen, for example, affects the lining of the uterus and can, increase incidence of uterine cancer in patients taking this compound. Lazofloxifene has a more favorable side effect profile. It is not as likely to increase uterine hyperplasia. Patients seem to not have a lot of the similar effects of other SERMs like vaginal dryness and like sexual dysfunction. So we're really excited about this compound because it's got a more favorable side effect profile than other SERMs while still providing the same anti-cancer benefits.
And then just on the general ballpark of things like epigenetics and mutations, how might lazofloxifene's activity at mutant estrogen receptors, such as those found in therapy-resistant breast cancer, inform the use of bone microenvironments affected by malignancy? And I know we're in preclinical, but do you have any kind of thoughts on that?
Absolutely. So mutations to the estrogen receptor are pretty common in advanced and metastatic disease. And so a lot of times when we talk about bone metastasis, it's very likely that these patients will at some point acquire mutations to ER. And a lot of those mutations make it constitutively active. And so ER is a protein that has a three-dimensional structure. It has kind of an inactive and active conformation. And so when this protein acquires these mutations, it can kind of get almost locked in an active conformation, which makes it not really susceptible to a number of compounds because they bind the ligand binding pocket. And if that pocket is closed, they can't, get in to bind the estrogen receptor. And so in addition to being constitutively active, it often makes these cells resistant to treatment. But lazofloxifene has shown to still have a high affinity for mutant ER, which is great for patients with advanced and metastatic disease who may have a mutation. So it's still going to be an effective treatment regardless if ER is wild type or mutant.
Mm. What are the most promising areas of future research regarding lazofloxifene's mechanisms or clinical application in bone biology?
I think that moving forward, the clinical implications of this is that hopefully through more rigorous clinical trials, that lazofloxifene will be sort of a standard of care for patients with breast to bone metastasis, because hopefully it will alleviate a lot of the side effects and symptoms of bone metastasis, not only the metastatic burden, but also the increased fracture risk, bone pain, things like that. So hopefully we will see sort of a shift to using these new generation endocrine therapies more often than not for just the increase in patient care.
Mm-hmm. Are there any known drug interactions that might be relevant as this moves towards clinical trials?
Absolutely. So lazofloxifene is currently in a phase 3 clinical trial with abemaciclib as a combination therapy. Often endocrine therapies are prescribed in combination with PI3 kinase inhibitors or maybe cell cycle inhibitors like abemaciclib or ribociclib. So I'm sure that moving forward we will see a number of combination therapies with lazofloxifene, just depending on the subtype of cancer that patients have. Like I said, PI3 kinase inhibitors are really frequently prescribed for patients with mutant PI3 kinase or PTEN loss. So that's, I think, kind of the next few clinical trials, similarly to elacestrant, which is a compound that was just approved a number of years ago, but it's currently in trials with all of these different combinations that are frequently used in with endocrine therapies in ER-positive breast cancer.
What are your thoughts on potentially testing combination therapies in these preclinical trials? Is that
Yes, and so that is a really exciting focus of our lab as well, is repurposing different drug compounds that may have either an orphan status by the FDA or be approved for other diseases. So we have done high throughput screening on the cancer cells and osteoblasts to try to find compounds that will preserve the health of the osteoblast while reducing cell viability of the cancer cells, in hopes that we'll find something that will, be a great combination to reduce metastatic burden in, the metastasis in the bones, while also preserving the homeostasis that exists within the bone under normal circumstances. That's really what we would like to seek to do, is to give patients an option that is going to be minimally destructive to their normal bone architecture while still reducing the metastasis.
Is there anything in the preclinical research that might hint at the proper amount of dosing or dosing strategies that might be on the horizon to be effective, or is that out of the ballpark?
So that is a really difficult question for us to answer because our preclinical models are usually mice. And mice metabolize drugs at a very different rate than people. We like to use a conversion chart to sort of try to figure out what is an equivalent dose for animals. But I think right now really we'll have to look at the ELAINE 3 clinical trial to determine if a dose, decrease or escalation is needed, and see what kind of side effects patients are experiencing on that particular dose of lazofloxifene. But we'll see what data comes out of that trial.
So being that we're at the Endocrine Society annual meeting, I'm interested to find out what research you thought was particularly interesting amongst your colleagues, or what presentations really stood out for you and that might have implications to your future work.
Yeah, absolutely. I think that really a big focus of the conference was on the effects of obesity and aging on different reproductive systems, including bone, because as women age, our sex hormones change, and 1 in 2 women will experience osteoporosis postmenopausally. So that is a really exciting field of research that relates back to my work and kind of this story. But additionally, I really think that all of the research being done on GLP-1 inhibitors is really important and very interesting. I didn't see a lot of work being done to connect GLP-1 inhibitor use and cancer progression, but I'd be really interested to see more of that kind of work showing that, maybe a decrease in obesity caused by GLP-1 inhibitor use might, either decrease cancer incidence or cancer progression or something like that. But I think all the work being done in that field is really exciting and extremely important.
When it comes to kind of selecting your animal models, is there anything related to kind of how they're sired or mothered that helps kind of narrow down the risks of certain factors?
Yeah, it's a really good question. So we work primarily with animal models because I study the bone. There's not a really great model to study bone in a petri dish, unfortunately. It's just such a complex organ system. There are people working on it. There are some really exciting things that are happening, but for now, the actual bone, I think, is kind of going to be the gold standard of looking at drug compounds and bone metastasis. And so we, in our lab, study all of this in the context of PDX model, so patient-derived xenografts. So these are cells taken from patients that are implanted in mice, but usually mice have an immune system. And if you take a human cell and you put it in a mouse with an immune system, it will just clear those cells out. It's like a cold or something. It just sort of gets rid of them. So we work with patient-derived xenografts in immune incompetent mice. So these mice don't really have a functional immune system. They don't have B and T cells, so they can grow these human cells just fine, but in a whole animal system. So that's sort of how we answer the questions that we have about drug compounds and metastasis. It's also really great that we can use human cells for this because, like I said, mice are different from people. And while they're a great animal model, there are things that are just not possible to study. And so when we're thinking about how these drugs affect the microenvironment, one of the things that we do have to do is not only ask questions in our immune incompetent mice in a metastatic setting, but also in immune competent mice. So that's sort of one of the things that we're going to do next is look at how things change when we add in the immune component, because that is a big factor and a big part of what happens inside of the bones.
Mm. How are you mapping maybe other factors? Because when we think about some of these trials, and I already mentioned the use of like machine learning to maybe pick up some insights that might not have been picked up in clinical trials. I'm also thinking about like the cross-referencing of different things across specialties that I feel like we're not necessarily focused on because everyone's busy. So how is there a plan or a process around gathering maybe additional data that might be used later on in your work at all?
I think the short answer is yes. So our work generates huge data sets. So we do RNA sequencing and we get back data on 30 to 60,000 genes, and we do proteomics analysis and we get back 10,000 proteins, and we do this in triplicate across multiple models. So we do generate huge amounts of data. And because we use animal models, we not only have data on the cancer cells in these animals, but also the mouse cells that exist. And so we do have kind of a push in the lab to learn how we can enhance our bioinformatics skills to not only mine these huge data sets, but also how to sort of analyze this data together in an integrated way. So we can talk about how gene expression changes protein expression and what that means for drug response.
Interesting. Well, this has been a great conversation, Emily. Thank you so much for joining us.
Thank you so much for your time. It's been a pleasure.